Hello, everyone. This is Chadi Alraies from RSH 2025 in Riyadh, and really privileged to be with Dr. Oscar Mendiz to talk about aortic regurgitation and the management with TAVI. Oscar, thanks for being with us.
It's my pleasure. Thank you for the invitation.
Yeah, as we know now, right now, we have a good indication for aortic stenosis, but aortic regurgitation is less likely. So you're going to present a very challenging case. Can you talk us through it and what was your technique?
Well, this is a case that we did in Buenos Aires. Actually, pure aortic regurgitation, not a common indication in my country. It's probably no more than 2 or 3% of the cases. We don't have, or we don't still have the dedicated devices, so we have to use regular devices. In this case, we use the MyValve device. Was a case with pure aortic regurgitation, no calcification on the leaflets. So during the implantation, there was an extra beat, a premature ventricular beat, and there was a pop-up. So it was very difficult to handle this situation. The valve was snared. It was not possible to move to the descending aorta, so we had to land the valve in the ascending aorta. Which was a little bit dilated because in aortic regurgitation it's usually dilated, and then we had to go with a second valve.
Yeah.
For that situation, we use a faster rapid pacing. We use 220, and went a little bit deeper. The case finally did very well, but it shows the limitation of the current devices because the landing is sometimes not so precise,
Right.
and it's the potential complication. But there are some cases that you have to do it. There are absolutely surgical contraindication, and we still don't have dedicated devices.
Absolutely. So in these cases, and from your experience, is it recommended to do a self-expanding valve or balloon expanding valve?
Well, that's a very difficult question for me. I don't have the proper answer, probably. If in my situation, I would choose one or the other according to the aortic angulation.
Size, yeah.
If it is a very angulated aorta, like this case, which was almost horizontal, I would rather go with the balloon expandable valve. If it is a different situation, I could use self-expandable. And also, I would take into consideration the annulus size because if it is big, probably in some situation, my valve that we have with the 32, it's for bigger annulus could be an option.
Yeah.
We can use the other balloon expandable. The other we can go +4, +5 centimeters,
Yeah.
and it can fix the situation. With the self-expandable, we have the limitation of the annulus size.
Yeah. So just from this experience, what kind of lesson learned to avoid this from happening from somebody who have the same case going forward? Is it the rapid pacing? Is it the implantation, deeper implantation?
I would rather advise to go with a very fast, rapid pacing, probably to test before that the capture is completely perfect, to wait a little bit to have the pressure very well down, and then go slowly and for the implantation. I wouldn't go too deep because if not, probably you can also have ventricular embolization.
Yeah.
So I would go with a regular, positioning,
Yeah.
but taking into consideration that some balloon expandable especially have some foreshortening. And if you have a huge annulus, the foreshortening is a little bit bigger. So it's also important to have into account.
In terms of, as you mentioned, there is aortopathy usually associated with AI or AR, right? So is there any special consideration in terms of device or manipulation of the shaft of the device as you're delivering the valve?
Well, that's also a good question. In some cases, I use a second bend to the wire. I introduce probably at 15 or 20 centimeters from the tip a second bend shaft to try to help the device to orientate a little bit better. A stiffer wire can be used, like Landerquist or or Backmeyer, something similar. But in this case, I also introduce a second bend. I think it helps because when you push the wire against the apex, you get a little better orientation, especially for horizontals aortas. When you have a dilated aorta, is challenging. Also because if you have a complication, and also for a self-expander because you don't have aortic root contact, which can help you to stabilize the valve.
Yes.
So there are additional challenges.
Yeah. And that's, I think, why we are kind of late in creating a new iteration of the valves for the AI, because its anatomy is completely kind of different beast and the behavior. Well,
Absolutely, absolutely. We are waiting for that. Unfortunately, we have used this kind of valve before when were introduced for the aortic stenosis by transapical. Now we are waiting for the new device to be used transfemoral.
yeah.
I think it's a great advantage because it's a different fixation system and it would be very helpful.
Absolutely. Well, Dr. Mendiz, thanks again for sharing your experience. As you said, all the challenges you went through, I think every cardiologist go through, and
Yeah.
everybody trying to create his own creative way of helping these patients.
Thank you so much for the interview.
Thank you. Watch these videos and others on YouTube channel and Face and also on the website. My name is this is Chadi Alraies coming to you from RSH 2025 in Riyadh. Dr. Mendiz, thanks again.
Thank you.
Yeah.